What's up, folks? Back at it. I do not. I repeat, I do not own the rights to this music. do not own the rights to this music. do not own the rights to this music. not own the rights to this music. I do not own the rights to this music. You know what? I believe I'm gonna just stop jamming out. It's too much. Just keep saying that like a robot. Keep on keeping on, man. Keep on keeping on. Oh yeah, I know I preach about splitting your ruts, but we got this pretty much packed down our path, so I'm gonna just ride it out. You know, we good for now. Really don't have to split them. Just keep riding your tracks. Look at that, I'm in third gear. Now watch what I tell you. Watch somebody come through here with a dozer. Someone's gonna come through here with a dozer and clip it off, and that's gonna slow us down. Watch. I can't take this. I need some music. I do not own the rights to this music. Woo! Man. Ain't that worse? I see you up on that tree. I do not own the rights to this music. rights to this music. I do not own the rights to this groovy music, y'all. I do not own the rights to this music. I'm looking at them dragonflies, and I seen this thing on TikTok. I'm wondering if this thing really works. I seen this thing on TikTok. It's a dragonfly attached to some type of stick or something, or string or whatever, and you hang it. They say you hang it on your porch, and wherever when you're outside, you hang it up. And the idea is that it's supposed to keep mosquitoes and other insects away. I don't believe that. I don't know. I just find it hard to believe that a fake dragonfly. I didn't know dragonflies ate mosquitoes, to tell you the truth. I did not know that. But yeah, that was funny. Look at all the dragonflies. Okay, I ain't gonna hit you, man. I ain't gonna hit you. You're good, brother. You're good. What? I just looked what he loaded me with. I got a freaking bucket full of slop. I do not own the rights to this music. This is the same song they got me for yesterday. And I could have swore I said I do not own the rights to this music. Folks, I gotta take a quick little long break. And yeah, I don't own the rights to that music. Oh, no. All right, and putting on the seatbelt. I do not own the rights to this information.
We refer to as Medicaid money laundering, which has shifted significant costs from states to the federal government. And these tactics involve states and hospital systems developing creative financing schemes that give the appearance of the state making an expenditure on the hospital, but it's just an illusion. But the federal government then transfers large funds to the state that the state then uses to make significant payoffs to the hospital systems. So that corporate welfare really ratcheted up during the Biden administration, and Medicaid payments in many states for many hospital systems are now well in excess of Medicare rates. So the main reforms that I'd say we focused on were reducing these state financing gimmicks and really addressing the corporate welfare and have a bipartisan history. So the reforms that Paragon were advocating were actually identical reforms to what President Obama proposed in 2012 and 2013 to phase down, to limit states' ability to use these financing gimmicks and then limit the payoffs to the providers to no more than Medicare rates. We don't think that the Medicaid program should be paying more for able-bodied working-age adults than the Medicare program pays for seniors. Under the status quo financing arrangement, you would see the health system reorient away from providing services to seniors, threatening their access. So I think my favorite personal provisions are the ones that reduced and limited the Medicaid money laundering apparatus. I think the other reforms, and Julie talked about them.
Let's pause and just take these one at a time. Julie, how does that align with what you found and how Medicaid is operating with hospitals and with states?
So this fight over who pays what and how states raise their share of the money dates back to the late 1980s. And Brian is right; it's been bipartisan. Democrats have tried to slow it down. Republicans have tried to slow it down. I don't think anybody objects to the idea that that states should pay their share and should find a way to pay their share. But basically every state has done this, I think, except Alaska. So it is definitely baked in, and I think the question was, do you want to freeze it? Do you want to, how do you want to roll it back? In the end, a lot of people, what it means is that states aren't going to be able to come up with their share if they can't do it this way, and they're going to end up cutting back. Those are the only options, unless states are going to raise taxes across the board for their citizens.
Benjamin, your hospital serves as the only hospital for many residents in rural South Central Kansas. How much does Medicaid account for your budget right now?
About 10% of our budget comes from Medicaid.
And so what kind of budgetary impact are you preparing for due to these changes? What will it mean for the health care you provide, for your workers, your staff?
Yeah, the short answer is we're unsure how much this bill will hurt us, but we do know that we'll be expected to do more with less, and so we're preparing for that.
And how are you preparing?
We've frozen wage increases until we learn more. We have a very tightly managed position to control committee where we're not filling even essential positions, really counting on our existing team to do more with less as positions naturally turn over. We are deferring maintenance on key equipment and the replacement of key equipment. These are things that we eventually end up having to pay the piper for down the way. but we're preparing in the short run because we will know in the coming weeks just how bad this is going to hurt us.
Well, and we heard Brian there say that part of the problem with Medicaid that he's pushing to address is hospitals inflating what they're charging the federal government for in regards to health care. Your response to that?
Our profit margin is 0.5% in the fiscal year ending June 30. And we have recovered or are recovering from COVID. But I would say that we're a safety net provider that requires really all forms of payment to ensure that we can continue to care for all payers and those who can't pay. And so when we cut a significant portion of our reimbursement structure or payer mix, as we would call it, that puts all healthcare at risk because then we start evaluating which services we can keep or not keep.
So, Brian, 0.5% profit margin. Money laundering?
Amy, I would say rural hospitals are not the problem. The large abuses are from large hospital systems that have lots of political power. They're big insurance companies where this money gets funneled through. And the schemes have significantly increased. These payments, they're called state-directed payments, and there are additional payments that are made to hospital systems, quadrupled during the Biden administration. And the reality is states are doing this increased corporate welfare because it's all federal money. And I think that what states need to do, so states historically paid about 60%, states paid about 40% of Medicaid costs. They now pay about 25% of Medicaid costs. There's been a massive growth in the program, but the entire increase has been borne by the federal government. The state-federal partnership that underpins the program has become broken as states respond to these incentives just to fleece the federal taxpayer. And it is correct for the federal government to reduce the extent that states can engage in these games and inflate payments and just load the system with corporate welfare.
But Julie, as we're talking about it, it sounds like this legislation wasn't so much a scalpel as it was an axe. And so we can say on one hand, well, yes, rural hospitals like Benjamin's, 0.5% profit margin, they're not fleecing the system. But is the legislation designed in such a way to address issues like what Benjamin has laid out for us?
Yeah, well, it's a very blunt instrument, and it's going to basically throw it all back to the states, and every state's in a different fiscal position. Every state has a different relationship with its payers. But the bottom line is what we know, and Brian says it's not rural hospitals. When a rural hospital closes, it's not just the Medicaid recipients who get hurt, it's everybody in that area. And the hospital has to cut back on its most expensive departments, which includes things like maternity. Then everybody, no matter what kind of insurance they have, is going to have to go somewhere else to have their baby.
Benjamin, what sorts of services are you considering cutting back on right now as you think about the possible loss in federal funding?
Well, our vulnerable services, as you mentioned earlier, maternal health and pediatrics, we reopened an inpatient pediatric ward a year ago, planning on, or really even it was just 6-7 months ago, planning on the need to grow our maternity services and care for newborns. So we had some significant philanthropic help to get us to reopen that unit. It was closed during COVID, and bringing that back. Those are a few of them. And I say in general, when you're looking at these cuts, it's the old, it's the poor, it's the youngest among us, and it's moms that are most affected. And those are the services that we have to figure out how to sustain through philanthropy or otherwise when we see these cuts coming, because they are high cost, low reimbursement services, but they're crucial for our communities. We say in Spanish in parts of rural Kansas, las madres tienen las llaves del reino, which means the mothers hold the keys to the kingdom, and moms manage the health of everyone else. And so if we're not actively caring for mothers here, but the entire families and entire communities are at risk. So those are the ones that we're focused on sustaining in creative ways as we expect these cuts to get worse.
We're talking to Benjamin Anderson, the CEO of Hutchinson Regional Healthcare System in Kansas, Brian Blais, the president and founder of Paragon Health Institute, and Julie Routman, chief Washington correspondent for KFF Health News. We also got this message from Katie in Florida.
Trump claims that the reason they're making the cut is to prevent so much fraud and waste. And in fact, the patient whose money he is cutting rarely commit any fraud, and the vast majority of fraud is done by the providers, the doctors and facilities, labs, hospitals, whatever. Millions and millions and millions of dollars in fraud by those people. And instead of cutting the benefits, they need to provide a little more money for enforcement with the providers.
Thanks for that message, Katie. Julie, what do we know about how much fraud is actually happening?
So there's fraud in the healthcare system because there's so much money in the healthcare system. But as Phoebe mentioned, most of the fraud is committed by the public and not by patients. Because, as I pointed out, patients don't get money for Medicaid. Providers get money for Medicaid. And yes, there's been for episodes of years, even the last of fraud in the state required to have a fraud unit. I mean, there's still a lot of work, but I say there's a lot of money, and it's not that hard to defraud federal healthcare programs. It's not that hard to defraud private healthcare programs either. Healthcare fraud is a huge issue, but that's not really what this bill takes aim at.
We heard from Janelle in Ohio who emails, I'm trying to restore my Medicaid. The political issues surrounding it have made it a difficult process. I'm 60 years old with health issues. I do work part-time and am a caregiver for elderly relatives. My observations have shown me that the majority of fraud and abuse within the Medicaid system is coming from businesses, insurance providers, and shady medical services, not from the recipients, yet people like myself are the ones being hurt. And Stacey emails, I live in Arkansas, which is the model for work requirements. This has created serious hurdles for those in Arkansas who would otherwise qualify for Medicaid services. How are we going to ensure people don't fall through the cracks? Brian?
Yeah, I think there is significant fraud throughout our federal health programs. In Medicaid, we estimate over the last decade there's been $1.1 trillion in improper payments. A lot of the improper payments in Medicaid result from the fact that states get 7 times more federal funding when they enroll somebody under the ACA Medicaid expansion than when they enroll someone who's a traditional enrollee. There's significant fraud that is being perpetuated by unscrupulous brokers who are taking advantage.
But again, that's on the broker, the hospital, the administrative side. But for individuals, we're getting a lot of messages from our listeners concerned that individuals will fall through the cracks.
Yeah, I mean, I think in terms of, you can think about it in 2 problems. You have people enrolled in programs who aren't eligible, don't know that they're, and some of them don't know that they're enrolled. And then you have the issue of people who are trying to get signed up for a program, are eligible for the program, and are not able to. And I would say the former problem is at least 10 times bigger than the latter problem. There are huge incentives for brokers, for insurers, for providers to maximize enrollment in these programs. So we have, between the ACA exchanges and Medicaid expansion, we estimate 12 million people improperly enrolled. Now, the big problem there is that the Biden administration pursued a policy agenda of enrollment, maximizing enrollment, regardless of whether people were eligible for the programs or not. And one of the features of the One Big Beautiful Bill, with both the exchanges and with Medicaid expansion, is to ensure that people are eligible for the programs in which they're enrolled, so that the resources, there's more resources available to the individuals that truly need the program and are eligible for the program.
Julie, talk about this enrollment question and what you found in your report.
There's a decades-long body of research that says when you increase the barriers to enrollment, yes, you keep out people who are ineligible, but you also keep out people who are eligible. For years and years and years, one of the ways that states controlled their Medicaid expenditures, remember, Medicaid is a huge piece of every state's budget, was by just increasing the length of the application for Medicaid. If you had a 2-page application, you would end up with a lot more people on the program than if you had a 20-page application. A lot of people don't make it through that 20-page application. Again, yes, you're catching people who are ineligible, but you are also preventing people who are eligible, and we have seen that over and over and over again.
Benjamin, before we let you go, there's a $50 billion rural hospital fund within Trump's tax and spending bill called the Rural Health Transformation Program, and it aims to address access, improve training and health outcomes. There are other objectives as well. How much will this help make up for the loss in Medicaid funding for a hospital like yours?
Well, the bill was passed to save money on, or to spend
All right,
on
folks.
Medicaid, so it does not make up the whole amount. I anticipate.
Getting pretty boring, so I ain't gonna hold you up.
We don't know. Yeah, we don't know.
I'll catch you guys later.